For the meeting of the New York City Health and Hospitals Finance Committee. Today's meeting is officially called to order. I'd first like to propose a motion to adopt the minutes of the Finance Committee meeting held on April 8th, 2025.
Yes.
And I vote yes, so the minutes are adopted. The Finance Committee is now going to convene an executive session because the matters to be discussed involve confidential and privileged information and quality assurance health information relating to particular patients and matters relating to proposed or actual litigation. May I have a motion for executive session?
So moved.
Okay, all in favor? Say
Yes.
Any objections? Okay, the motion's approved. We'll convene an executive session. So those Okay, thank you, everyone. We are now reconvening in open session. We have several resolutions to get through and then a financial update. So the first one is a bond issuance financing approval, and I will ask Linda, Tom, and Brenda to take us through. Linda, maybe you can read the resolution first.
Thank you.
Thank you.
Authorizing and approving the adoption of the resolution presented concurrently with this one entitled New York City Health and Hospitals Corporation Health System Bonds 2025 Series Resolution, providing for the issuance of a series of health system bonds, 2025 series bonds, in a principal amount not exceeding $250 million for new money purposes to finance the cost of various capital projects and expenditures at New York City Health and Hospitals Corporation, with an issue date no later than December 31st, 2025, at a fixed interest rate of not more than 6%, and with the final maturity of the 2025 series bonds not exceeding beyond 2055. So what we're asking here, some background on our bond financing program. The Systems Bond Financing Program is authorized by a general resolution, which was first adopted by the board at the inception of our bond program in 1992 and was most recently updated in 2020. A general resolution authorizes and sets parameters for a particular financing program and structure. Under our general resolution, our bonds are secured by a primary pledge of our health system healthcare revenues and also features a capital reserve fund, which is backed by the city. Series resolutions under the general resolution authorize specific financing transactions and typically will include a specified amount or maximum amount and more specific parameters. The series resolution also authorizes execution of certain documents that are necessary for bond financing transactions. So we are here today with 2025 series resolution. We are bringing this forward because we have a need for more capital financing. We have, in most recent years and really for the past decade or so, relied much more heavily on the city to fund our capital needs and look to our financing as more of a minor supplemental source. We have, over that same period of time, and particularly over the last few years, really taken steps to improve our capital needs assessment and planning capability, as well as our capacity to execute capital projects. And as we have done that and really done a better job of assessing our needs, the gap between what's available in our city-funded capital budget and our identified critical capital needs has grown. So the city capital plan is quite large at $2.68 billion through FY25. However, over the work I've just discussed, we have identified additional capital investment needs of approximately $1.6 billion for that same period. And we have identified $577 million of projects that we're proposing to be funded by health and hospitals directly. And the current request is asking for $25 million related to those projects to be financed by the 2025 series bonds. Our selection of projects that H&H is financing are primarily revenue-driven projects or projects that have to do with end-of-life or good state of repair equipment and infrastructure that contribute to or doing these projects will contribute to savings with respect to maintenance and repair costs and also limit downtime related to problems in that infrastructure or equipment breaking down. We also looked at projects that were ready to launch over the next approximately 2 years and where the work had been completed to the point that we could assess the full need with some level of confidence. That work will be ongoing, and so we will continue to build on the capital plan and identify additional projects for financing, and will periodically update our projections and requests. Another point we wanted to make the board aware of is our capacity to take on this financing. As I mentioned, we have relied more heavily on the city in recent years, and so our bond activity has been fairly low over the past more than 10 years. Since the inception of our program in 1993, we've issued a total of $3.3 billion of bonds, including refundings, and we estimate that those refundings have, over the life of the program, saved us approximately $145 million. But you can see from the table in the upper right that our activity has been fairly low, and particularly for new money uses since 2013. Because of that, we have a lot of our debt has dwindled significantly over time and will be amortizing over the next several years. So the bar graph, shows our current debt service related to bonds. And we have two series outstanding. And we have a number that are amortized by FY31. So you'll see in FY31 a significant drop in our debt service and then very low level annual debt service thereafter. Because of this, we feel comfortable that we have capacity to take on new debt. We also think it's important to note that capital expenses are one of the few components of the Medicaid rates that are adjusted for individual facility cost. So we estimate that over time, approximately 60% of the debt service that we take on will be reimbursed by Medicaid.
As Linda mentioned, the system has identified approximately $577 million worth of priority capital projects. This chart lays out the spread between infrastructure, medical equipment, and technology. You can see the bulk of the $577 million consists of infrastructure, roughly 3/4 or 76%, and the balance is split between medical equipment and technology at 11% and 13%. We had asked our business units, program units, including OFD, strategic sourcing, and information technology services, to provide cash flows for what the spread would look like for these priority projects. And this table here lays out what that spread looks like. As Linda mentioned, what we're focused in on is the timing of these specific needs, and of that total amount of the $577 million, the action or the financing today is for approximately $250 million. I'll hand it over to Tom if you want to give a little bit of a...
Yeah, so this is the cash flow that's basically we're using to estimate our upcoming plan of finance, which is $250 million, so run through January 2027. Is a timing cash flow, as you can see, comparing to the pie chart. It runs from December 2024 all the way out to, fiscal year 2033 for the life of the $577 million.
And the $250 million, again, is focused on spending through January of 2027. So, again, it's a portion of that whole view. The following slide shows you what the spread looks like of that $250 million. Again, same categories, spread between infrastructure, medical equipment, and technology. Again, infrastructure makes up the bulk of the spending at over 50%, followed by medical equipment and technology.
This slide is very similar to what Linda was referring to in terms of capacity taken on the new debt. The bar graph on the right-hand side that is very similar here. The only difference is that we're laying in the debt service for the upcoming deal, which we call a wraparound the existing debt service. You notice here the level debt starting in 2031 is now fairly level, as opposed to just a cliff off from 31 out to, or at least 32 to all the way out. I think the other one that we want to highlight here is, again, this is a new money deal. We're funding capital project, but we're also funding our capital reserve requirement under the general resolutions and, of course, cost of issuance. On the next slide, just to show you In terms of the rate environment that we're in, as you can see, we have been issuing, like Linda said, all the way back to 1993, but this line graph is showing the last 15 years. The different rate in terms of between the 10-year and the 30-year under the MMD. The MMD is basically, it's just a benchmark that we use in the municipal market to price our tax exempt bonds. And you notice there the differential, call it in 2010A, when we were issuing there, the MMD for the 30-year was 377, and then the 10-year at that time was roughly 230. And then, it fairly go down in the last sort of low end of it, the last deal that we did in 2020. It was sort of the great moment when the rate was fairly low. You notice that the 30-year was 139 and the 10-year was about 70 basis points. But as you notice, starting in 2022, when the FOM start raising their rate for 11 times, from 22 to 23, it fairly trending upward, and that's where we're currently sitting at, with the 30-year currently roughly around 450 range, and the 10-year is around the 330 range. So we're going into a market in a high rate environment, but we think we can get through it because I think our upcoming debt is fairly short comparing to the last time, so we're going to have some benefit on the short end of the curve in the current market environment. Okay, so the next slide is our MWB designation policy. This is, again, forming our underwriting group for the upcoming deal. We actually selected our underwriting group back in October 2024. The board approved that, and we are planning to use the same underwriting group that was approved for that. And then at the same time, we're also going to have a designation policy, which is very similar to in 2028, minimum of 30% and no more 6% allocated for each of the firms that are listed here. One additional note, in addition to the 7 you notice there, the board also selected for the first time a minority firm in the senior pool, which is going to be a carve-out for them because they're on the senior pool selection, whereas the second bullet, the listing there, is for the co-manager pool. And then, of course, we're also going to try to include a selling group that very similar to the New York City financing group, which we try to fold it into our deal as well. And then,
Great. Thank you. So I'll open it up to the committee for any questions or comments. Nope. Okay, great. So I would just one comment from me. I'm very impressed with the thoughtfulness of the capital planning process and how you guys have managed your debt portfolio. We've talked about that at other times at Capital Corp, but to have the capacity, because obviously the backlog of infrastructure need is tremendous. We get a lot of help from the city, but clearly there's a lot more need. And so just how you guys prioritized and managed the both in terms of timing and readiness of the project, but the types of projects, as you highlighted, Linda, that you guys focused on. So looking forward to it. Also just the debt portfolio in terms of structuring it, where you have the capacity and the lives of the projects, keeping it short helps us in this higher interest rate environment. So good luck. And with that, I will ask for a motion to approve the resolution.
So moved.
All those in favor?
Yes.
Yes. Any opposed? Okay, so the resolution is approved. On to the next one. I think this is the first of 3 with respect to coding. So, Mr. Melican, are you going to do the resolution and lead us through? Great, thank you.
Thank you. Authorizing New York City Health and Hospitals Corporation, the system, to increase the not-to-exceed total contract value by $6.6 million, which includes a 10% contingency to its previously negotiated and executed contract with FICARE Holdings Group Incorporated, to provide hospital and professional coding and billing services. The cumulative not-to-exceed value for the hospital and professional coding and billing services shall increase from $12.4 million to $19.1 million for the remainder of the contract term of 2 one-year renewal options exercisable at the discretion of New York City Health and Hospitals Corporation. I'm Bob Melican. Margie Carlin is unable to join on vacation today. And just to give you a little background on what we're looking for. We are looking to increase the value of our contract with FICARE. FICARE provides really two component services for us. First is hospital billing, the hospital outpatient billing service. And then the second component is the professional billing. And within professional billing, they provide two services. One is the actual coding of that professional claim, and the second is the billing and follow-up on these claims. So these are the two services that they provide for us. This $80 million is a very significant portion of revenue that we generate from the professional billing. This has been a growing area of revenue for us, and FICARE has been key to that service. On the next slide, just kind of want to run through the history of this contract and why we're asking for a not to exceed now. This contract was procured in 2021. We went to the board in March of 22 and entered a contract with FICARE in September of 22 when they started under the new contract. We went through a full RFP and negotiated on the open market for this. The contract will expire in 2027. Our contract will exceed our not to exceed amount in January of 2026. So we have a little time before we run out of funds, but that's why we're here today. What we have been doing and why we are here to increase the not to exceed is that FICARE has been adding new volume for us. We have really moved more volume to them to generate revenue and to improve our operations. We have our physicians are capturing more revenue, and the more charges they generate, the more codes that we're able to code and claim. We are also now coding for global billing services at 2 of our hospitals. So where we're not generating a bill, we were not previously coding those claims because it didn't generate revenue, but we are now coding them to improve our operations, understand how our physicians are charging, and where we have work to improve our operations. The next two are self-pay. We were previously not billing patients for professional services for self-pay. We now are asking FICARE to code those services, and we are producing claims and bills for those patients. And then we found a new revenue stream where we weren't coding for our nurse practitioner services. We found nurse practitioners at some of our hospitals where H&H could bill. We were previously not billing, so we've been moving those claims to FICARE to code and then subsequently bill those services. So the volume that we've been giving them is within the scope of our current contract, but we've been moving new claims to them. FICARE has been a very responsive partner for us. We find them to be a good provider, and they really do have the capacity and the expertise to meet our volume requirements. So vendor performance on the whole has been very good. This outlines our rating of them, and we do find them an excellent partner. On the next slide, for vendor diversity, FICARE is a WBE vendor, so our diversity goals have been met, and we're asking for that $8 million to the $6 million with that contingency so that we can provide services through the end of this contract period. We'll be going for a new RFP when the contract expires, so we'll be back for that.
Great. Thank you. Any questions from committee members? No? Okay. Thank you for the presentation. We'll motion to approve the resolution.
So move.
All those in favor?
Yes.
Great, thank you. The resolution is approved. The next agenda item is Ms. Perez?
Yes.
Okay, great, thank you for supplemental coding.
Thank you for allowing me to present today. So we are asking for an increase in the NTP for our supplementary coding teams of $4.7 million. This includes a 20% contingency to its previously negotiated executed contract with 3 supplementary coder firms, Sutherland Healthcare, Eclat Health Solutions, and Sutherland Healthcare Solutions, to include the cumulative not to exceed from $3,061,000 to $7.7 million for the remainder of the contract term of 2 years with contract term of 2 one-year renewal options exercisable at the discretion of New York City Health and Hospitals. So the Revenue Cycle Services are requesting this increase for this contract for the three firms. They provide service support for our emergency department coding and our inpatient coding. These services include coding and reviewing. Since these services were not procured, since they were procured, the coding support volume has significantly increased. As coding expertise is in demand across the revenue cycle. Next slide, please. So the supplementary coding RFP did go out in June of 2022 for the amount of $3 million. The contracts were issued in August and December of 2022 and will expire in 2027. We have spent to June $3.6 million. And I know that we are over budget. I think we did request it sooner, and then the process was put in for us to bring it here. So that is why we're here at that amount now. And as a result of the overall expertise needed across the revenue cycle initiatives, the volume has increased that we are pushing to the supplementary coding firms. So we are. Some of those initiatives have to do with AR data improvement and charge capture, our risk adjustment capture, our facility for coding, our HCCs and CRG scores, which is the Medicare's hierarchy comorbid conditions, and the clinical risk groups for Medicaid. Also, coding is more involved in assisting with non-coding functions required for billing and compliance, and internal resources are being used to resolve edits and do not bills so that we can get those charges out with meeting timely filing and avoiding late charges. We have increased, and we did have an increase in review when we transitioned to Experian. So that requires coding support from our staff. So we are requesting this NT with a 20% contingency to cover that volume and business change needs. That also have to do with staffing changes that took place in coding over the last few years that required additional volumes to go out to the vendor firms. The vendors are performing well across the board. They are responsive in many of the areas, and we feel that they're a good partnership we have with all three of them. They are meeting the 65% across the three vendors. And so we are asking for the $4.7 million of increase for this budget.
Thank you. Just to clarify that both of these contracts that we just approved are for coding, but they are for different coding needs, right? And both of them are revenue-generating contracts for us, and so the fact that we are spending a lot on it is because our volume has increased and that we are generating more revenue for the system. So I wanted to make that statement as a clarification on what we're approving here. So I open it up for the committee members for any other questions or comments. If not, thank you for the presentation, and I will ask for a vote on the resolution. All those in favor?
Aye.
Aye. And any opposed? Okay, so the resolution is passed. And Ms. Perez, I think you have one more take us through for NIM.
This is a little more exciting.
Okay, great.
So this one is for a new process. This is for the automation of coding. And so we're asking to enter into a contract with NIMS Health, Autonomous Coding Services, not to exceed the amount of $8.1 million, which includes a 20% contingency fee for the contract, and the term of 3 years and 2 renewal options, of course, exercisable by the discretion of the system. And just a little bit of background. This is a brand new vendor. We do not have any process or contract at this point. And so the demand for, as you can see from our previous request, for coding support and expertise have increased over time. And so up to this point, it has increased our overtime spend and our vendor spend. This is an ongoing increase in demand that we're seeing coming in the future, and so we're expecting that moving to automated coding will affect that. We have an increasing emergency department and inpatient volume, expansion of professional billing, as Bob talked about in the previous contract request, and addressing coding-related edits and denials, which I mentioned as well. And to date, there is no contract for autonomous coding, which includes artificial intelligence. So the benefits do include, of course, the automating code assignment increases coding efficiency, reduces manual errors, and accelerates the revenue cycle. Coding pattern recognition will help ensure accuracy and compliance coding standards. Meeting coding standards, reducing the risk of coding-related errors, improving coding consistency. Real-time feedback for the clinician supports the clinician in maintaining coding accuracy, facilitates compliance, and streamlines the coding workflow. Integrates with the electronic health record, enhances interoperability, reduces duplication of efforts, and supports a more streamlined healthcare information exchange. Coding compliance checks reduces the risk of audits and denials, improving the overall accuracy of compliance in medical coding, and adaptability to coding changes will be, of course, much more quicker and up-to-date across the system, and a decrease in the reliance on current coding contracts over time. This was our RFP criteria. We did require that at least the firms had 5 years experience in working with AI, including medical coding, demonstrated high accuracy rate, demonstrated evaluation process for checking coding quality, experience in working with at least one multi-hospital system, and of course meeting our MWBE certification and utilization. We had a multidisciplinary evaluation committee, which included HIM directors, myself, the revenue officer, Martin Carlin, and Epic, and a medical professional as well. The overview of the procurement, we just started this a week to date. Last year, we got the contract approval from the CRC, and it went to the city record in September. Later that month, we had the pre-conference proposals, questions, and in November, we had proposals from 10 vendors. In March, we had the vendor presentations. April, we did the reference checks, and the evaluation committee final score, MIMS Health scored on top. Here you have, this is mostly software, so the recommendation is a 10% diverse vendor component. So we are asking to move forward into contract with MIMS Health for $8.1 million, which also includes the 20% contingency I mentioned. And does anyone have any questions?
Any questions from committee members? I have one question. This is software how does it interact with the 2 prior vendors? Would they?
The expectation is that this software would do simple coding for both professional and hospital billing. And it will begin with ED, emergency room, but the option and extension can include other areas as needed from a business needs perspective. Mm-hmm. So they will be covering some of the services that right now are manually done by both vending contracts requested for the NTEs today.
Okay, so it might actually streamline and reduce their need as well. So great. It's good to see the technological improvements.
Go ahead.
Sorry, do you, I don't know if everyone here covers all of the sort of coding services that we have, but do you foresee needing this kind of excess for other coding services coming down the pipe? Because we had 3 resolutions today.
Yes, some of the things that are happening today is we're having every account with which is whether it's simple or complex, right? So the two vendors that we have talked about today needing the additional funding for do these things manually, right? Everything is done manually. The idea is that this service will cover the simple coding, and what we'll have is the exceptions. So things that are not able to pass coding or are complex would go to our staff, our resources, reducing the services that are being provided by the vendors.
It would be good.
I'm sorry.
I'm sorry.
And like it was stated before, the two contracts perform two different things. So professional coding is conducted by FICARE, so the expectation is that would be reduced on our TEA hospitals initially. And for the hospital billing, it would be our ED services.
I understand the intention, and the automation is always great, but I think from a financial perspective, it will be helpful to understand what other potential coding services might need an expanded budget and what that total number might be.
I think that's a broader question for
Yeah.
John and Margie
Yeah.
to go and look. But it's the right question, right? It's you're sort of asking what's the bigger universe, what's the
Yeah.
whole universe.
Yeah.
We're sort of with this contract sort of stepping our toe into this world, and partially deciding based on the success of this contract how far we're going to go. I know that there's an AI bot right out there ready to replace me, so it's hard to know like exactly what the limit is this is going to be.
Because we're individually resolving 8 million, 4 million, 7 million. Like, what is the bigger number?
Yeah, I mean, the whole universe, right, would be all of the revenue
Right.
collection activities that we have, and what portion of those activities will become automated by AI. It would seem like a lot, because it is, unlike a lot of things, there's not a ton of creativity that you want or outside information, right? It's as one of the big things about coding is that you can only code what's on the page. Other things may have been done, right? But you can't code them, right? And if the doctor or other practitioner did not write it down, it didn't happen. So there's nobody to really ask, and you don't want anybody to be creative. You want them to read the sheet, read the record, read what was done, and establish the correct codes for those things. So, I mean, again, as you said, you're leaving out the more complicated ones to start with, where we still have coders who are in real time reading the records and putting in the codes. But I do think this could become something, and we'll get back on what the universe is to you.
And I didn't make an assumption that these technologies included AI, but that's a whole other conversation, right? Because AI isn't perfected.
John, what's our insurance revenue number, approximately per year?
I'd say, do you know what it is?
Maybe 6 billion.
Yeah, 6. Yeah, 6 billion.
So 6 billion in some way is the total universe of insurance billing, right? So I mean, all of that money is being brought in by someone reading a record or seeing a service and figuring out who is the appropriate person to bill. And as we said, we've even broadened it to say, in order to we want to have clear expectations of productivity for people. And because we are proud to serve many people who don't have insurance, now we're also coding the records of people who don't have insurance, not for the sake of generating a bill, but because that's the standard of productivity, right? So so in some way then the universe becomes even bigger than the dollar of revenue, because it's trying to code all of our records so that we can say, this gastroenterologist is doing this scope of work, and this gastroenterologist is getting paid the same, but it's only doing this amount of work.
Right.
which has never easily been possible because the hospitals and the services vary on the degree to which they're uninsured. Like Jacoby's uninsured percentage is smaller because it borders Westchester, right? So you get more people with insurance, right, than say Met. So, we've never, we can look at revenue, but it's been harder to look at productivity unless you start coding the records of the people who we're proud to serve who can't pay.
Yeah, I mean, the intention makes sense. I'd just like to know the magnitude, an estimated magnitude of the increases.
Will do. Okay.
Any other questions or comments? Okay, so I'll call for a vote on the NIM Health resolution. All those in favor?
Yes.
Yes. And that resolution is approved. Our final one, Micheline Desargues, if you could please.
Hi, good afternoon, everyone. So for this one is the disaster recovery consulting firms. We are requesting authorizing the New York City Health and Hospitals Corporation, the system, to execute a contract with Haggerty Consulting, Inc. for disaster recovery consulting services at a not to exceed amount of $8.4 million for a contract term of 5 years and 2 one-year renewal options exercisable at the discretion of the system. So basically, this contract allows New York City Health and Hospitals to get support that is required around disaster emergency time. We require a disaster recovery and recovery consulting firm provides basically help with our fast-growing portfolio that is both federal and state when we deal with hazard mitigation, repairs, and recovery. In recent years, we have secured and continue to develop additional FEMA funding for post-Hurricane Sandy disasters. We've had the more recent Hurricane Ida and Hurricane Ophelia. In doing so, or dealing with these disasters, basically we need a strategic advisory there to continue to basically respond to these requests and being able to maximize our reimbursement through our appropriate compliance with our FEMA requirements when we are performing these activities. The new disaster recovery consultant is critical to maximize these dollars and also for our ongoing proper efforts to complete the disaster recovery work. That work is normally funded for the FEMA-funded projects. They're funded by what's called DAC, which is the Direct Administrative Cost Pot of Money. And I will turn it over to my partner, Nicole Schenk.
Afternoon, everyone. So the RFP criteria for this was set up by both OFD and jointly with finance grants team, because once onboarded, the disaster recovery firm will be working closely with both parties to assist with OFD on the more technical side of A&E, FEMA eligibility assessment, and on the grant side, grant submission, compliance review, and other tasks. So we evaluated based on the years of experience for all the qualified bidders, as well as the size of the projects they have managed in the past, to make sure that they're comparable to the sizes of projects that we manage and the complexity involved with our portfolio. And we have the evaluation committee consists of both OFD and finance representatives. Next slide. So we issued our RFP late last year in November, and we have received 8 proposals. We conducted further interviews and presentations, and Haggerty Consulting was the highest scorer of them all. And Haggerty presented the MWBE utilization plan that satisfies the system's requirements.
So we are requesting the authorization of New York City Health and Hospitals Corporation as the system to execute the contract with Haggerty Consulting, Inc. for disaster recovery consulting services at a not to exceed amount of 8.4 million for a contract term of 5 years and 2 one-year renewal options exercisable at the discretion of the system.
Any questions from the committee? I just have one question. This is a new vendor for us, right?
Correct.
And so you did do reference checks. Have they had similar experience, and did those all come back?
Yeah, I think they stood out in terms of our vendors with the reference check, right, of the work that Haggerty has done historically, which will be very beneficial to us, specifically dealing with the city and city disasters. So which is really critical for us, both for FEMA as a funder and also with city projects. So those two things are really key when we're securing these types of vendors.
And doesn't the city have Haggerty on their
Yes.
team? Yeah.
Mhm.
The city uses Haggerty as well, which
Okay.
can help us with communication a little bit. Yeah.
Okay. All right, great. So I will,
No.
no contingency.
Yeah, it's an estimate of what we would expect.
Right. Okay, if no other questions, I will call for a vote. All those in favor?
Yes.
Anyone opposed? All right, so this resolution is approved. Thank you. So thank you, everyone, for the presentations. We do have a bit of time here, but not a lot. But we do want to go through the finance update. John, if you can kind of give us an overview of how we've been doing and then talk a little bit about some of the risks that we're seeing. And I know we want to have some time for a value-based care program update and potentially talk a little bit about the budget for next year, but if we have time. And then there are some other materials that we won't be able to get to, but are submitted for the record, so.
Yeah.
Okay,
No,
great.
thank you. Thank you
Thank
for
you.
your time. And we'll get through it all quickly. I will say that, we think the system's performing, very, very well. Pretty much hitting all of our marks. Through April, we had a positive net budget variance of 1% or $190 million. The next slide, please.
Oh,
Can you just go ahead and?
Oh, okay, that's fine. Oh, yeah, no problem.
slide's not moving.
So we're 1% ahead of budget, right? We're spending a little bit more, about 235 million more than the budget, but offset by revenue of 425. But again, that's kind of our, nothing unusual here. We believe, right, that margin will carry us through to the end of the year. We felt like we had a pretty good close. We're still trying to add it all up. We do want to say thank you to Health First and Metro Plus, because they helped us at the end with a big lump sum transaction. The outpatient UPL from FY24, right, finally arrived. So we drew down those monies, and again, that was in our plan, but they helped push it so we could get to the end of the year mark. I'll say the other remarkable number keeps going up for us is our measurement, and this gets back to James's question of the patient care revenue. Is we keep track of that. And that's up almost $900 million year to year. In the package here, we finally call the purple chart. We keep track of the actuals from 24, 25, and James is right. The number for 25 actuals was about $5.7 billion. So, and then we also measure that, against the budget. Our capitation payments, risk pool dollars, we call them. They've dropped about $200 million year to year, but we forecasted that drop, and that's primarily because of the recertification process has kind of run its course, and that we were forecasting that would result in a drop in covered lives. So I think we're on track. We saw that, and then the state's also tightening up on the premiums. But overall, I think revenue's performing very well. Volumes are performing very well. I think even compared to some of our counterparts in the city, we're doing very well on volume, up 2.1% on discharges and almost 17% on outpatient. The strategic financial initiatives, right, we're on the mark there. We'll hit the 1.2 by the end of the year. On the next slide, we just talk about our cash position. Today is a very good day, right, because we've gotten got paid our big $500 million dish payment from the city, so we're sitting on a pretty decent bolus of funds. But we'll be okay through July, August, right? We'll continue to track the cash position, but we feel like we're in a pretty okay place there. And then that takes us to the managing of the risks. And here, obviously, we got to talk about, the federal bill. We're still evaluating the bill. We know it's going to have a pretty substantial impact across the country on, healthcare systems and healthcare in general. The governor released impacts, right? And we're trying to triangulate from the different sources that we have, but the governor released impacts that the bill, when fully developed, fully annualized, fully implemented, $13.5 billion impact on New York State's healthcare system, primarily Medicaid. It could result in 1.2 million people being newly uninsured. So those are hard numbers to really accept. The budget director came out, with his own numbers. He said the impact for this year could be as high as, I think, 750 million, and then that would grow to $3 billion. So these are very large numbers, and we're still trying to, sort our way through it. The state has to make some, very difficult decisions, we think, here. The first item, the essential plan, the bill eliminates premium tax credits for those individuals that are actually legally present in the United States, but tax credits are no longer allowable. The state had, under its own innovation, had developed what they call the essential plan. And the essential plan is a very, I think, we've done very well with the essential plan. We make, the rates that it pays are considerably higher than Medicaid. The risk pool dollars that we earn as a result of capitation also very significant. So that's a big impact for us. And that would, go into effect as early as the beginning of this next calendar year. The other measures, also disturbing, but Medicaid work requirements, new burdensome administrative enrollment requirements, renewals every 6 months, auto recertifications, all these things, right, will accumulate and result in more uninsured individuals needing to be served. So, but those come in a little bit later. So many of the actions are backloaded, and we'll have to, follow those as things develop. Our strategy is, various what we call lines of defense. The first would be what we term the average commercial rate. This is a state-directed payment in CMS parlance. At the last year, about exactly this time, CMS had passed a managed care rule, and this is all part of their health equity agenda, to give states the opportunity to set a benchmark Medicaid rate at the average commercial rate. And that's a pretty substantial increase when you consider the amount that commercial payers reimburse providers versus Medicaid. Sometimes could be 2 or 3 times higher. So once that became final rule, we immediately began developing that application. We got it out the door finally right around Christmas time, but it is in play with CMS. We've had a series of questions that have been exchanged, and we've responded to those with the help of the state. And then in the bill, there's a provision whereby there's a grandfather clause that clearly states that if your state-directed payment applications, or preprint they call them, has been submitted prior to the enactment of the bill, right, then it should be considered. So we feel very good about that. We feel like that's actually, there's a little bit more security, being brought forward by the legislation. So we will continue to work on that. That will generate a significant amount of money for health and hospitals, and that will, in essence, I think, provide an initial cushion, right, to absorb some of these other actions that are coming forward. The other lines of defense, right, if after we burn through those dollars, we'll go back to using the DISH funds, and health and hospitals has a very large allocation of DISH dollars under the statewide allocation, so we would fall back on those for covering the cost of the uninsured. Emergency Medicaid still appears to be intact. We will use those dollars as people present for trauma in our emergency rooms, where we can bill Medicaid and draw federal share pursuant to the bill. So we will continue to watch this very closely and then develop our responses as they get clearer to us.
The DISH cuts were postponed to No.
Well, that's a good, I appreciate that question, Frida. We were tracking the bill, and the delay in the cuts was in both the House and Senate bill, but it dropped out of the final bill. And what we've been told is that it will go into the appropriation bill. And we've not heard a lot of discussion about it not being in the final appropriation, but again, there's more to be done there. But that's certainly very important to us. And I think there's a lot of red and blue states that would, support, the extension of the cuts. So, but we'll have to track that. Yeah. Yeah. So that's kind of, where we sit with the risk. We're also tracking FEMA dollars, right? We have a last tranche of FEMA funds. We're in discussion with FEMA about trying to secure all those dollars. But again, that is something we will have to track. We feel okay about it now, but we don't know in this environment.
That's from COVID time?
Yes,
Yeah.
it's another, I think, $300 million, yeah.
Okay. Got it.
I think these other slides, right, are just kind of more explanation of the variance. I could pass by those. There's the purple chart, performance, and then that takes us to VBP. Is that okay?
Yeah.
Great. Good news, right? Which is important in thinking about all of these changes. So we did receive recent news from Metro Plus of our 2023 calendar year performance. And the blue bar, the first chart there shows that our blue bar continues to go up, right? So I think that that's a really positive development. These are our VBP and pay for performance earnings. So these are the quality dollars that we receive that are in our value-based contracts. That's really trying to incentivize our doctors not only to provide care, but to really care for the population of members that are risk attributed to us. So you can see here that we had our best ever performance in 2023. And we do believe that these positive results have had the positive benefit on Metro Plus, where they tied for #1 ranking in New York State for Medicaid and tied for #2 ranking for Essential Plan. So those are directly correlated because we are so much of the Metro Plus network. So really exciting to see that the blue bars are continuing to increase and that we're being consistently, we're showing consistent improvement. Next slide. It's not alone to Metro Plus. We
Yes.
are also seeing very positive performance for Health First. So a couple of things to note here is that the blue bars are also continuing on an upward trajectory. We earned slightly more money in 2024. So these are 2024 results from Health First as compared to 2023 on the last slide. But in 2024, slightly more, but it's still more. So that's exciting. And you can see on the chart on the left, everywhere that we're highlighting in green, we're showing that there is a year-over-year improvement in that quality measure. Which is really significant and really exciting. Maybe the thing that is most relevant or most laudatory for us to talk about is that when you look at the Health First network, which is representative of most of the providers in the New York City market, our sites are ranking, in the top 10. And we're really eating up all of the top 10 slots. So you can see that, whether they're our FQHC sites, you can see Morrisania ranked #1 in Health First Medicare network, or some of our bigger hospitals like Elmhurst, Kings on the left in the Medicaid side. Our sites are showing up and doing the work and really ranking very high in the Health First network. And I think that this is a really important and proud moment for us that we had kind of similar results with Health First last year. So it wasn't a fluke last year that we did really well. We're continuing to see that consistency into 2024. So,
Another.
yes.
Great.
Yeah, I think I'll just add is we've been going through and introducing ourselves to the rating agencies, and we've kind of, we take a moment to humbly brag about it. I think they're actually very surprised by our performance,
Yeah.
right? And we are very proud of it, and it's a lot of hard work, right? You don't just get lucky on these. You gotta
Right.
work at them. So.
Especially the consistency and
Yes.
that continued trajectory. It's wonderful. Yeah. Great.
Couple minutes on budget development?
Yes.
Yeah, so I'll just start and maybe I'll turn it over to Tasha to help me here. And I just kind of, we go, we have a very disciplined, budget development process, and we try to make it as democratic as we possibly can, right? We just don't assign numbers. There's a lot of back and forth and work that goes on with Ms. and Tasha and their counterparts. We divide it into 3 phases. So there's a phase 1, right? And again, as we're building the base and making sure that the numbers are lining up, everybody agrees with the numbers. And then phase 2, we kind of get a better understanding of what we think the gap is, the problem that we have to solve for. And then phase 3 really evolves around, what are our budget themes? What is our strategy to close the gap? And further expand revenues and make it the important investments where those dollars are best placed. So with that, again, I'll say that we've constructed the budget around these themes. The process really culminates next Tuesday, right, when we meet with the CEOs and CFOs and we all come together. And that's the place and time where everybody gets a chance to raise their hand and say, yes, I agree with the budget, or no, I don't. If they don't agree with the budget, we got more work to do. We've never had a situation where we don't eventually get to an agreement. So I just thought that little bit of background might be helpful. Tasha, you want to go through the themes or Micheline?
Sure, we can go very quickly. I know we are running out of time, but one big thing when we look at the expenses, we know that our budget, we could do a little bit more to add to the dollars on the PS and the OCPS side, but strategy-wise, we're looking at the models, areas that we know needed the support around OFD and overtime. Those are the models that we're able to complete and adjust into the upcoming budget. We're also looking at primary care staffing, the opportunities there on both the expenses and the revenues, and cross-facility partnerships are big for us for regionalization and clinical efficiencies. And so those are some of the areas that the facilities will speak to in the upcoming meeting. And our workforce plan, we've had a lot of great success creating the workforce plan, and we're continuing our glide path for the reduction in locum spending, which we're seeing happen already.
We're seeing that in the results, yeah, good.
And the other area around infrastructure investments, as we heard on the capital side, that's an area that facilities struggle with. They do use some operational dollars when they have emergencies for equipment, assets, and areas around that. So we worked with them to see what their needs might be to help better plan, and so hopefully the capital process can support in that area as well. So that's where we are for phase
Great.
3.
Thank you.
Very promising.
And hopefully reduce overtime and all of those emergencies and
Yes.
things that we have to grapple with. Great.
Yes. So we can, on HERC, I think, we're doing just fine there. I don't know if Mary's here. Hi, Mary.
Yeah, no updates on HERC. We have one site as of July 1st, and the city's adopt plan, they put up sufficient funding for our 25 and 26 budget projections. So
Great.
No concerns.
Okay. Yes, as we wind down, I mean, it's just amazing the work we've done. So it seems anticlimactic to report on, but yeah, not at all forgetting about all of the great stuff. So.
Yeah, tremendous amount of money, and I'll say the city's been good partners with us, right?
Yeah,
These guys do a
very good
tremendous job, but I think they have a great relationship with the city, and the city's, right, we've managed to figure it out as we go,
Yeah.
right?
Thank you. Okay, great. Well, thank you for the thorough report. I'm sorry we didn't have more time for you. Any questions from committee members or comments? Nope. Okay, great. So is there any old business or new business to bring before the committee? There being no further discussion, meeting adjourned. Thank you all.
Thank you.
This meeting is no longer being recorded.